Hello everyone, let's continue our class. Last class we have reviewed some knowledge about electrophysiology features of cardiomyocytes, and today we will study antiarrhythmic drugs. Antiarrhythmic drugs in clinic divide into four kinds. The first kinds, class 1, they are sodium channel blockers. And we also divide the first kind, sodium channel blockers, into three kinds, 1A, 1B, and 1C. 1A, potent sodium channel blockers, such as quinidine, such as properphenol. Later, we will study these drugs, pharmacological effects, clinical using, and idle section. 1B means the mild, lowest potent sodium channel blockers, such as lidocaine and phenytoin. Later, we will study these drugs. And 1C, most potent sodium channel blockers. The second class of antiarrhythmic drugs, they are beta receptor blockers. Do you remember we have studied beta receptor blockers, such as properphenol, such as metoprolol. And in this class, we will study these drugs to treat tachycardia. The third class of antiarrhythmic drugs, they are potassium channel blockers. The drug is amiodarine. So later we will study amiodarine's pharmacological effects and clinical usings. The fourth case of antiarrhythmic drugs, they are calcium channel blockers, CCB. Before we study CCB, now my question is, we studied CCB and we know we have two prototypical agents. One is verapamil, the other one is nifedipine. We use CCB to treat arrhythmias, tachycardia. So in these two prototypical agents, which drug is used to treat tachycardia? Verapamil or nifedipine? Yes, very good. We use the drug is verapamil. Okay. Antiarrhythmic drugs divided into these four classes. And let's study the details. The first kind, class 1, sodium channel blockers. Sodium channel blockers, that's now we have known, divided into 1A, 1B, and 1C. 1A, potent sodium channel blockers, and includes these drugs, such as quinidine, procainamide, and disopyramide. These drugs potent block sodium channels, but also block potassium and calcium channels. So we will study quinidine as the prototypical agent. 1A. 1A, potent sodium channel blocker, and quinidine can potent block sodium channel. And in low doses, quinidine can block sodium channel. And if we use large doses, quinidine also block different potassium channel and also inhibit L-type calcium channel. Except this channel's inhibition, quinidine also inhibit M receptor and also inhibit alpha receptor. So let's study the quinidine's pharmacological effects. In antiarrhythmic drugs, the pharmacological effects are a little different. Means we will study the drugs' electrophysiological effects. Last class we have reviewed cardiac myocytes includes three electrophysiological physiological characteristics. The first one is autorhythmicity. The second one is conduction. The third one is ERP and APD. So the first effect of quinidine inhibit autorhythmicity. We have known what's the meaning of autorhythmicity. One action potential and then external stimulus and external action potential, external response, external heart rate. And we call this figure is autorhythmicity. And we also studied autorhythmicity determined by phase 4. So that means determined by two channels. One is sodium channel, the other one is calcium channel. And just now we have mentioned quinidine. It is the patent sodium channel blocker. So patent block phase 4, patent block sodium channel. So the first effect, reduce autorhythmicity, means reduce heart rate, can use to treat tachycardia. The second effect on conduction. We have reviewed last class. Conduction means determined by phase 0. Depolarization velocity of phase 0 determine conduction. And we also studied phase 0, the major channel is sodium channel. Quinidine is the sodium channel blocker. So block sodium channel means block phase 0, inhibit conduction. So the second effect of quinidine, very easy, inhibit conduction. And the third one, inhibit conduction, eliminate re-entry. So last class we also have known re-entry is the basis of arrhythmias. It is the normal impulse, one conduction and one heart rate stopped. But for some patients, and they have this triangle, so re-entry, and we call this re-entry. The patients use quinidine can block here, so eliminate re-entry, inhibit conduction, reduce heartbeat. The third figure is action potential duration and ERP, effectiveness refractory period. What's the meaning of APD, action potential duration? Means from phase 0 to phase 4. ERP means from phase 0 to phase 3. We have known means during this period, we give stimulus, external stimulus, no response, no heartbeat, so can reduce heart rate. And APD and ERP, during this period, phase 0 to phase 3, phase 0 to phase 4, the major channel is the potassium channel. And just now we have mentioned, quinidine not only can inhibit sodium channel, but also can block potassium channel. So quinidine can prolong APD and prolong ERP, can reduce heart rate. And the next one, quinidine has negative inotropic action. Negative inotropic action means reduce contractility. Why? Quinidine has these effects, negative inotropic action. Because quinidine not only can block sodium potassium channels, but also can block calcium channel. Yes, block calcium channels show have negative inotropic action. These are quinidin's pharmacological effects. And then we use quinidin, we can find after use quinidin, inhibitor phase 0, inhibit conduction, prolong APD and ERP, and inhibit sodium channel, so inhibit autorhythmicity. So reduce the heart rate can use to treat tachycardia. Used to treat tachycardia with kind of arrhythmias, we can use quinidin. At first, we should know quinidin is the broad-spectrum antiarrhythmic agent. Broad-spectrum means the all sinus tachycardia, and then atrial fibrillation, atrial flutter, and here is the supraventricular tachycardia, and here are ventricular arrhythmias. So ventricular tachycardia, ventricular premature, ventricular fibrillation. Yes, quinidin have therapeutic effects on these arrhythmias. It is the broad-spectrum antiarrhythmic drugs can use to treat this is kind of arrhythmias. But later, we will study quinidin has lots of idle sections. So these days, only convert atrial fibrillation and convert atrial flutter. So atrial fibrillation and atrial flutter, the first choice agent still is quinidin. So the clinical using, though quinidin is the broad spectrum antiarrhythmic drug, these days only convert atrial fibrillation and atrial flutter as the first choice. Quinidin's idle section includes gastrointestinal stimulation. The patients use the drug maybe feel upset, emesis, and vomiting. And some patients use quinidin also have these adverse actions, such as inhibit heart rate, so induce conduction blockade. Few patients also induce ventricular tachycardia and ventricular fibrillation. Why? We still unclear. Maybe because quinidin can block M receptor. The third idle section of quinidin is synchronism, and the patients use the drugs because quinidin come from this quinidin is come from this plant synchrotrin, and have the special idle section. We got this synchronism. Some patients use the drug, induce tinnitus, dysaconia, black water fever, black urine. It is the special idle sections of quinidin. The reason because quinidin is the plant resources. And the next idle section is hypotension. Because quinidin not only can block sodium potassium calcium channel, but also block M and alpha receptor. Block alpha receptor show visual dilation and reduce blood pressure, induce hypotension. The first drug, 1A, patent sodium channel blocker, And just now we studied quinidine. This is the second drug, procainamide, similar to quinidine. Similar to quinidine, but maybe super to quinidine. Do not inhibit M receptor, do not inhibit alpha receptor. So that means procainamide, no atropine-like syndrome, no phentolamine-like syndrome, no these adverse reactions. Similar to quinidine, so similar pharmacological effects. Procainamide also block sodium channel, potassium channel, and calcium channel. So similar effects can reduce autorhythmicity, inhibit conduction, and prolong action potential duration, prolong effective refractory period. Similar pharmacological effects means similar clinical using. Procainamide, it is one of the patent sodium channel blocker in 1A, and it is one of the broad-spectrum antiarrhythmic drugs. Broad-spectrum antiarrhythmic drugs means sinus tachycardia, atrial arrhythmias, ventricular arrhythmias, has therapeutic effects. But this drug not as the first choice for its kind of arrhythmias, because this drug has some adverse action, such as this is SLE, lupus-like syndrome. Nearly 20 to 25% of patients long-term use procainamide induce SLE. You have studied immunology and you have known it is one kind of autoimmunology disease, and it is a serious adverse action. So, procainamide, though it is the broad-spectrum antiarrhythmic drugs, not as the first choice. Okay. Next kind, 1B. 1B, mild potassium sodium channel blockers. The drug is lidocaine. Do you remember lidocaine? We have studied lidocaine. It is one of the ILA, local anesthetics. Local anesthetics and local using have local anesthetics action. It is lidocaine. Today, we intravenous using lidocaine can only effect on Purkinje fibers. So now my question is, do you remember where are Purkinje fibers? In atrial, ventricular? Yes, in ventricular. So lidocaine only effects on Purkinje fibers. What's the meaning? That means lidocaine only used to treat ventricular arrhythmias. Yes, for this reason, lidocaine only used to treat ventricular arrhythmias. Lidocaine is the 1B in the 1B, mild patent sodium channel blocker, but also can block potassium channel? No, promote potassium channel opening. The first effect of lidocaine can reduce autorhythmicity, because we have studied autorhythmicity determined by phase 4 by sodium channel or calcium channel. Lidocaine can inhibit sodium channel. So inhibit sodium channel involved inhibit phase 4, inhibit autorhythmicity. On the other hand, lidocaine promote potassium channel opening, so increase potassium afterward, and then maximal diastolic potential increase enlarged, and far away from threshold potential. So far away from transport potential, and then also inhibit autorhythmicity. The first effect of lidocaine from these two pathways inhibit autorhythmicity, inhibit heart rate, inhibit ventricular rate. We can use to treat ventricular fibrillation arrhythmias. The second pharmacological effects of lidocaine, conduction. We have known conduction means the phase zero, determined by sodium channel, and the lidocaine is the mild sodium channel blocker. So, mild sodium channel blocker in therapeutic doses cannot affect conduction, but high doses lidocaine block sodium channels and inhibit conduction. The third effect of lidocaine, relatively prolonged action potential duration and relatively prolonged ERP. Though lidocaine can short action potential duration, also short effective refractory period, but short action potential duration more obviously than ERP. So that means eliminate re-entry because lidocaine can short action potential duration, also short if ERP. But in the new after use lidocaine, the red line, in the new curve, compared to action potential duration, ERP relatively be prolonged. So relatively be prolonged by lidocaine means external stimulus, no external response, no heart rates. For these reasons, we use lidocaine to treat tachycardia arrhythmias. And because obviously first pass elimination, so we couldn't oral administration lidocaine. And local administration means the local arrhythmias. And used to treat tachycardia, we use lidocaine intravenous using. Intravenous using lidocaine can treat arrhythmias because lidocaine only effect on Purkinje fibers, so only used to treat ventricular arrhythmias. Used to treat ventricular arrhythmias, such as ventricular premature contraction, ventricular tachycardia, ventricular fibrillation, all kinds of ventricular arrhythmias. Lidocaine should as the first choice. Maybe the patients are near patients with ventricular arrhythmias. Maybe the patients have myocardial infarction with ventricular arrhythmias. No matter the reason, each kind of ventricular arrhythmias, the first choice agent must be lidocaine. So we confirm this again. Each kind of ventricular arrhythmias, the first choice drug must be lidocaine. In fact, only one case difference. Digitalis toxicity, we use lidocaine as the second choice. The first choice agent is phenytoin sodium. Later, we will explain the reason. Here, we only need to know each kind of ventricular arrhythmias, no matter the reason. Maybe the patient's endocarditis with ventricular arrhythmias. Maybe the patient's angina pectoris with ventricular arrhythmias. No matter the reason, each kind of ventricular arrhythmias, the first choice agent must be lidocaine. Lidocaine have some interaction, such as inhibit central nervous system, so the patients maybe use the drug dizziness, and inhibit the cardiovascular system, so maybe induce conduction blockade or bradycardia. Okay. In 1B, the prototypical agent is lidocaine. Except lidocaine, we also use the second drug is phenytoin sodium. I mentioned phenytoin sodium. You should remember the drug you have studied. Phenytoin sodium is the drug used to treat which kind of disease? Doctors. You have studied phenytoin sodium. You use phenytoin sodium to treat, yes, epilepsy. It is the anti-epileptic agent. And this class, we will use phenytoin sodium to treat arrhythmias. To treat arrhythmias, phenytoin sodium similar to lidocaine. It is one of the 1B mild sodium channel blocker. So, and similar to lidocaine, phenytoin sodium only effect on Purkinje fibers. So means phenytoin sodium only used to treat ventricular arrhythmias. Only used to treat ventricular arrhythmias because similar to lidocaine can inhibit autorhythmicity, can relatively prolong ERP. So same clinical using with lidocaine used to treat ventricular arrhythmias, such as ventricular premature contraction, such as ventricular tachycardia, but we still remember that now we confirmed each kind of ventricular arrhythmia species. The first choice agent must be lidocaine. The second choice is phenytoin. But in clinic, only one patient, heart failure patients. Heart failure patients use cardiac glycoside overdose and induce dizzy-teles toxicity, induce ventricular tachycardia, ventricular arrhythmias. And the first choice agent is phenytoin sodium. Why? Because phenytoin sodium not only can treat ventricular arrhythmias, but also phenytoin sodium can competitively inhibit sodium potassium ATPase. Later, we will study how to treat heart failure. We use digitalis cardiac glycosides digoxin. This drug inhibits sodium potassium ATPase. This drug to treat heart failure overdose induce ventricular arrhythmias. And just now we have explained phenytoin sodium not only treat ventricular arrhythmias, but also can competitively inhibit sodium potassium ATPase. Means phenytoin sodium is the special antidote for digitalis overdose. So, the clinical using of phenytoin sodium. Heart failure patients use cardiac glycoside overdose. The first choice agent is phenytoin sodium, lidocaine as the second choice. Except digitalis toxicity, each kind of ventricular arrhythmias, the first choice agent must be lidocaine. Have you got it? The idle section about phenytoin sodium you have studied in anti-epileptic drugs. Do you remember the special idle section of phenytoin sodium? Central nervous system inhibitory, yes. And the special idle section is gingival hypertrophy. Gingival hypertrophy. The last cat in the first case, 1C. 1C, most patent sodium channel blockers. The drug is properphenol. Properphenol heavily block sodium channel. Most patent sodium channel be blocked by properphenol and also can block potassium channel. So the pharmacological effects of properphenol very easy. Block sodium channel, so inhibit autorhythmicity. Most patent block sodium channel, so inhibit phase 0, inhibit conduction. Inhibit potassium channel, so prolong action potential duration, prolong effective refractory period. Clinical using of properphenol. It is the broad-spectrum antiarrhythmic drugs. So atrial ventricular arrhythmias, we can use properphenol, but this drug is the most patent sodium channel blockers, means heavily idle section. So cardiovascular system, gastrointestinal system, a profound suppression of AV node, atrial ventricular node conduction blockade. So the drug properphenol, it is one of the broad-spectrum antiarrhythmic drugs, but it isn't the first choice agent. Means the other antiarrhythmic drugs ineffectiveness, we use 1C properphenol. Understand? Same kind with properphenol also includes flucainamide and encainamide. Flucainamide and encainamide, similar to properphenol, heavily block sodium channel but also block potassium channel. So, heavily inhibit autorhythmicity, obviously inhibit conduction, prolong action potential duration, and ERP. Broad spectrum, but just now I said, only used to treat the other antiarrhythmic drugs ineffective arrhythmias. We use 1C, these two drugs, properphenol or flucainamide and encainamide. Okay, this class we studied the first case, sodium channel blockers, and we studied 1A, quinidine, 1B, lidocaine and phenytoin, 1C, properphenol. Okay, see you next class.